Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Morning, everyone. Welcome to the Codecast Podcast. My name is Terry Fletcher. Hope you're having a good week and you are well into getting your Christmas and holiday shopping done. And hopefully you've been able to spend some time with friends and family as we get into this festive season. So today I open with a good number, 28,863 listeners when I woke up this morning. So that's a good number. Pretty excited about that. And we want to say, thank you to everybody and welcome if you're a new listener to the podcast. We've had some really good feedback lately. I just love everybody when you find me on LinkedIn or on Instagram or just send me a quick email. I really appreciate the comments and the really nice compliments. So thank you again for listening in. And this week, I always give you my Pittsburgh Steelers update. This week, we are playing the Raiders. Okay, don't even get me started. So just hope that it goes well. I'm just hoping that we come back with a win. And shout out to my Kansas City people out there. Make sure you beat the Ravens. That really would help me out a lot. Thank you so much. Anyway, we're going to go ahead and get started today. We got a couple of topics that I want to talk about. And these topics really focus on some things that Medicare and the OIG have been looking at from an audit perspective, and we have to be careful with some of these topics. And one is going to be a topic I'm going to revisit called Incident to Billing, or when we deal with our mid-level providers, when we bill it out as a physician service. And then another topic which I have not addressed recently, and it's something that, oh my gosh, it comes up all the time, and I think it's important to at least talk about it. And that's going to be when you get overpayments and what your responsibility is there. I actually had a practice tell me the other day, yeah, my doctor doesn't like to send back refunds, so then what do I do? I'm like, well, this really isn't an option, so let's have a chat about it. So you want to make sure you're compliant, you're not going to get in trouble, and you just know what you have to do there. But first, the Codecast Podcast is brought to you today by Movado Watch, one of the world's leading watchmakers. Movado, modern, ahead of its time. Movado.com. And Simple Health Radio, discussing topics related to your health and well-being. SimpleHealthRadio.com. Okay, so when we look at the Incident to information, just so everybody knows what that is, it's a Medicare billing term. It means that if your mid-level provider, and let's be clear on what that is a nurse practitioner, PA, physician assistant, clinical nurse specialist, clinical nurse midwife, anyone that can bill directly to Medicare. When they're billing for physician services, something that's normally provided in your office, when can you bill it under your physician and receive 100% payment? Because if you bill any of the mid-level provider services direct under them, you get 85%. So you do take a 15% hit, which makes sense. They're not the physician. And so there should be some kind of a reduction there. But we do, like and appreciate our mid-level providers because they provide relief to our physicians to make sure that, they can see a 30-patient morning or something like that, with them seeing patients and also mid-level seeing patients. And it really just gets patients in quicker and gives, patients an option to see a provider who also knows their clinical history and can prescribe medication and refer out for tests and diagnostics and things like that. So what really is, incident to billing? Medicare allows practitioners or physicians to bill Medicare for services provided by non-physicians as if the services were actually provided by a physician. Okay, so when you utilize this practice, the services first have to be furnished as an integral, although incidental part of the physician's personal professional services. So it's not something new or different. It's something that is part of what goes on in this physician's office. There also has to be an employment, evidence of an employment relationship. So when we talk about that we're talking about, a 1099 employee or a leased employee or a regular employee who's there getting hourly wage, etc. But the thing that you want to look at as far as these services is when not just are they an employee at the, and are the employee of the physician, because you can't pass along an expense to a patient that you didn't incur. And what I mean by that is, let's say that the the non-physician practitioner worked for the hospital, but your physician used them as a kind of de facto scribe for hospital records and their documentation. They use some of their information as part of theirs. You can't do that because you're not paying them any salary or anything. And every E&M service or dictated service that you have to have, that includes an overhead component for employees. So you want to make sure that you are not running into that trap. I'm seeing doctors do that all the time. But the other thing that's really important is that you have to also make sure, first of all, that the physician initiated care. So what that means is that your doctor basically did the new patient visit. They did the initial encounter for a new patient visit, or if it's an established patient visit, they actually initiated the new problem care. Now, question comes up, okay, so Terry, what if the patient's hypertensive? I'm like, okay, and there's a protocol for that and how they're monitored and the medicines and everything. They're seen a couple times in coming back to the office and follow-up visits. But they had something where, today they come in, they're scheduled with the nurse practitioner. They've got an elevated blood pressure, so the nurse practitioner's a little concerned and says, okay, we're going to modify your medication, which they can, by the way. Nurse practitioners have that kind of, I don't want to say power, but basically clinical authority to be able to modify treatment plans. And so can they then still bill this under incident 2? The condition didn't change. So the answer is yes. They're modifying something that's in place. It's not a new problem. It's an exacerbation of an existing problem. Now, would I recommend that they, let the physician know and say, is this, are you okay with this? That's not a bad idea, because one of the other rules that follow this means that the physician actually has to be in clinic when the patient is actually there. So if they're not in clinic, then you can't bill it out under the physician. We call it within yelling distance, where the doctor has to be able to come out and say, okay, I can help you right now. And so the other thing, not just the initial service the doctor has to provide, but it means first initiating care or the new patient visit, but it also means that the subsequent services, there has to be a frequency which reflects the physician active participation and management of during the course of treatment. So you have to reflect that, you're still actively involved in that patient's care. So generally the physician has the initial point of care, is what we like to call it. And different states have different rules, but this is pretty much how you look at it. And then when you're looking at this as well, and we call this direct supervision. So when the physician is actually there, then if there is a problem, then the doctor can come in and consult with the patient if necessary. But the other thing that you're also looking at this from a perspective that you're trying to see established patient visits. So this is really for established patient visits. It's so that, every patient can be seen quicker and get into the practice with, there's room there as far as in the schedule where it's not just the physician. And that's why this rule kind of came into play. But this is what's been coming up lately. And I think I mentioned it when I started, is that there are a lot of nurse practitioners who are hospital-based or work for the hospital. The physicians are really starting to use them and incorporating them into what they're doing, and that's just not appropriate. Remember, if you don't have some kind of an employee relationship, then move on. That's not your employee. Can you look at their information? Can you take it under advisement? Absolutely. You just can't look at it as part of something you can utilize as part of your documentation or anything like that. So that's where you've got to just be very cautious about what you incorporate into your practice when this comes up. The other thing, and this comes up actually quite a bit when we're talking about incident 2, while Medicare policies, they're kind of the template where other payers make their rules from. And so I have offices saying, well, this patient's Blue Cross, so I'm not going to follow that guideline. Well, that's your choice. But the problem is that if you don't have any guideline and you get called out on it, then the payer can just say, well, we follow Medicare guidelines. Payers are allowed to default to that even if they don't have that in writing. And so if they don't have a guideline, you need to have some kind of a policy. And I really believe that unless you have a policy from every payer, you should use the Medicare as your gold standard. If you have a payer that wants things done differently, and you have it in writing, then you could follow that. But if you're going to start doing the Medicare and then everybody else, then as just myself as a Medicare auditor, I'd like to see what the model is for every single payer out there that you're dealing with. And remember that if you do it that way, then you have to stop before you can even schedule an appointment or see the patient and decide, okay, what is their, what's their financial profile, so that we can then decide if we're going to be able to put them in with the nurse practitioner or the physician, or how that works. And I wanted to also comment the fact that, remember, this is the rules on established patient visits. New patient visits, there's state and federal guidelines on that. Nurse practitioners and PAs, they can see new patient visits, but know what your state says about that. For example, here in California, a nurse practitioner can hang a shingle out on the door and see, new patients as long as they have a collaborative physician within a 50-mile radius. But a PA has to be employed by a physician. And so, yes, they can see new patient visits, but you're going to take the 15% hit. You can't bill that out as if the physician saw the patient. So be mindful of that, because this is only for established visits. In the office setting as well, there's no incident 2 in the hospital, meaning that, your physician just has to be around or available if you run into an issue. The rule is, if the patient is sick enough to be seen in the hospital, then at some point the physician has to see them if they're going to bill it out under the physician. So an example, we have shared visits, which means your mid-level can work up the patient, but then the doctor has to come in to the room to see that patient. So you always want to be just mindful of that. Otherwise, that they have to have some kind of a documented proof that they were involved in the care, they completed the plan of care. Your mid-level can do the history and the exam, but then your doctor has to complete the plan of care, the medical decision-making portion, with some kind of a salutation at the end saying, I was directly involved in the face-to-face care of this patient, and I agree with the above. It can't just be a counter signature, and it says that in the Medicare rules. It says if it's just a counter signature, it's billed out under the mid-level. But let's say you have a mid-level provider that's called to the hospital because your doctor is either in a procedure or seeing patients and can't get there. So your mid-level goes over to see the patients and has a conversation over the phone with your physician about what to do and everything, documents that in the record. Does that qualify as a shared visit? It does not. There was no face-to-face encounter. So now that would be paid, or I should say reported or billed under the mid-level provider. You hope it gets paid, but you're looking at a lot of different payers that actually don't even recognize those providers. So just be cautious about that. Just want to make sure that you understand the incident 2 rules. I do a webinar on this, and I do it much more in depth, where I can show you dollar figures and if you should have them, and just really giving you insight and rules and sites and everything like that. So take a look at my website at terryfletcher.net if you're interested in really learning about the process of incident 2 billing and mid-level provider charging. Okay, so the next topic I want to get into is overpayments. There's no such thing as a Medicare windfall, and so we want to talk about that in a second. But first of all, this week's episode is also brought to you by Trident University. Trident is a leading online university serving members of the military, veterans, and corporate. Trident.edu. So when we talk about overpayment, and I said to a lot of offices, this is too good to be true. One of the scariest realizations, and this is a long-running mistake, especially where billing and payments are concerned. If you are in the habit of imagining nightmare scenarios, consider this. Your practice does its due diligence with an internal audit, and someone on staff realizes that you've been overpaid for services you incorrectly billed, and the too generous payer's identity is Medicare. Oops. If you ever find yourself battling overpayment obstacles like that, you need to act very quickly and make sure that you strategize to prepare for this worst case scenario. So in 2016, Medicare, CMS, mandated the timeline associated with Medicare overpayments using language and guidance from both the Fraud Enforcement Recovery Act of 2009 and the Affordable Care Act of 2010. The payback rules outlined by the agency indicated that the liability falls on the provider, whether the overpayments resulted from an internal fraud or just an honest mistake. Even if there's only suspicion of the error, you have to be mindful of this. And so here are the really how to be compliant. So first of all, reimburse the extra money as soon as possible. CMS rules stipulate a 60-day limit on returning overpayments to federal agencies. So that rule might seem simple, but you want to ensure you comply, since compliance failure could really lead to huge penalties for you. Regardless of fault and regardless of whether the overpayment was, full or partial, or in the case of an incident to reporting error or something like that, the practice must return the money. So when I mentioned the 85 versus, the 15% difference versus getting paid 100, if you notice you were paid 100% on a patient where there was no physician in the practice, if you do an internal audit, you've got to send that 15% back. The 60-day rule is designed to keep practices honest and on top of their auditing and accounting. While many practices may have occasional overpayment issues, everyone should have safeguards in place, like regular auditing, not just to audit, like what I do, to come in and find revenue opportunities and make sure that you're compliant with your E&M and procedural coding. That's what I do. You hire me to audit your records. I make sure that not only are you supporting what you code and what you bill, but that, when I look at it, I say, oh, look, they have time listed with smoking cessation. You're not capturing that service. Or if I'm looking at, heart cath interventions, this actually was a graft injection, we have to code for that. But we're talking about audits that you're just doing those due diligent compliance audits. And then trace the issue back to its roots. Once your practice has returned the initial overpayment, you have a 6-month window to conduct reasonable diligence to determine whether there are more overpayments on the same issue. This will involve going back 6 years in the case of an internal audit, though contractors are only obligated to go back 5 years. And then be honest in your accounting and return any additional overpayments that are uncovered. After you perform the audit of your billing practices, any overpayments you discover should then be refunded within the 60-day window. CMS goes with the assumption that you will fix any and all underlying problems to avoid this in the future. And the clock starts ticking on the date the issue is discovered, not the date of service or payment. That's important to know. You want to also, when you are looking at refunding the money, you want to also discuss or report how the overpayments were identified and quantified, and what corrective measures you've implemented to correct the issue. This goes a long way in good faith to Medicare. And so, if you have a culture of compliance and errors found, and evidence of the culture and continuous process, risk analysis, evaluation, and reevaluation, this will be in your favor. So really, take a look at that. If your practice does find evidence of overpayment, you have to have some, kind of explanation of how you identified it, the overpayment, and if applicable, what steps you are taking to avoid this to happen in the future. So I strongly recommend that you do these internal audits on occasion, and just, keep yourself, above water, keep yourself mindful, be proactive about it. And it just it goes a long way with Medicare, knowing that you're that honest with things that you're doing. Okay, so a coding question came in because we have the 2019 coding books that are out, and some of the new codes I've been talking about on different webinars, and I've been in seminars. I was just in Arizona recently, and I'm going to be heading to Northern California next month, but a lot of end of the year webinars to go over some of the new codes. And one of the lab codes came up from an Ohio client that said, Terry, code 83722, lipoprotein, direct measurement, small dense LDL cholesterol. This is a new code that's added to the lab section of the CPT book this year. High low density lipoproteins, LDL cholesterol, is known as bad cholesterol. New studies are showing that it's not only the quantity of LDL in your blood, but also the quality that's harmful. And so this is a new service to look at those risk factors when they do lab tests on you. So, there are multiple risk factors for small, dense LDL, such as high carbohydrate diet, especially refined sugars, uncontrolled diabetes, and high trans fat issues. So it can also be hereditary. So those are things you definitely want to take a look at. Okay, and I want to also just give you one of my personal tidbits this week. And one of the things, I might have mentioned it before, but I love the beach. The beach is kind of my safe haven, and Just had some personal challenges this week, so I've had to really think about the reflection, and it gives me a mind vacation just to look at the waves. It gives me some thoughtfulness, a way to put things in perspective, and take off reading glasses and unplug from my phone. And we had some storms not only when I was in Arizona but also in California. And after that, just the big waves and rainbows came over the ocean. And so that was just a fun thing to look at, and just realize that, there's always positive ahead. And if you can find that positive, if you see trees moving, I always think when the leaves are moving in the trees, I think they're talking to you. So if you can get a chance to go out, look at nature, and just take a moment and breathe, just take a moment. It's a very stressful time in December with holidays and family and friends and work, and all of us are doing year end and month end and trying to just get ready for the new year, and kids and you name it. So if you have a chance, just take that moment, unplug, and even if it's just 5 minutes on a break or your lunch hour or after work when you're sitting in your car, find that point of nature, whether it's a mountain you like to look at, if you live by the beach like I do, an ocean, you need to hear the waves, or it's just some trees you need to look at. Even if you see some really pretty flowers, just take a look. I know this sounds, kind of, sappy a little bit, and I don't really go there very often. But sometimes you just, as they say, you need to stop and smell the roses and just really take a look. So I hope everybody has a really good rest of your week. Get the rest of your shopping done, and have a great day. And I'll see you next time on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.